Hey guys, welcome back. My name's Gary Peterson, and today we're going to be going over the lost art of the EJ. Now, for all intents and purposes, this is a skill that is rarely practiced anymore. The IO has all but replaced it, which makes it that much more important that we go over it, that we learn as much as we can from past practice, from current clinicians. Just like any skill that you rarely deploy, you have to train on it that much more. So, basically, we've got the EJ. It's the external jugular. It should be within your scope of practice. It is still considered a peripheral line. It's got a couple extra aspects to it that makes it a little more dangerous, but we're going to go over that. So, indications. Basically, if you should be able to deploy a humeral head IO. It's more of the ACLS recommendation, closer vessel to the heart. The EJ has the exact same benefits of being a large bore line, accepting a large bore line, and being close to your immediate cardiac circulation. We're not really considering this necessarily for your cardiac arrest environment, although when I started doing it, the IOs hadn't really even hit the field yet, and that's very jurisdictional dependent. The other thing is, I was just recently speaking to one of my colleagues who said, yeah, we've got IOs, we've got humeral head IOs, which is fantastic, but our director is really concerned about cost, so he's put us under an obligation of trying 2 IV attempts before we go to IO. So in that level of service, you're going to be using an EJ more often. There are certainly lots of situations in which you only have this much access and up to your patient. You can have MVC where the dash has been rolled on the patient and they're pinned, so you're not going to have a tibial access for your IO. Various reasons. They could have a broken arm, different things where you're unable to manipulate into the anatomical position to place the IO. Basically, it's still within our skill set. We still need to learn how to do it and do it correctly and do it so that it's successful. So, here we are. So that's your indications. For your contraindications, basically it comes down to being able to recognize the anatomy. Assuming there's no actual, we're allowed to stick through a burn if that's the only site we have left, but extremely unlikely for this particular skill, and you'll find out why as we talked about the details. But, there are a lot of places where if you're unable to really identify the anatomy, then you're not allowed to even attempt the EJ. Some places that's not a requirement, and you can still make the attempt. But the reason why is, the reason why those contraindications exist is because of the damage to the structures underlying. So you've got major nerve bundles, but more importantly, you also have the carotid artery that's running in that same general area. If you went super deep and you spiked the artery, then now you've got an arterial bleed on an area of the body that is extremely difficult to compress the bleed without also causing airway compromise. If you nick the artery, it's going to swell the whole area. In fact, if you just even infiltrate the EJ, you're going to swell the whole area. So that's obviously a little bit of an issue. The EJ, low pressure, so it's not going to swell the area to the point of causing airway compromise, but that's certainly a potential aspect if you were to nick the carotid artery. So that's mainly why you're not even supposed to attempt this unless you have anatomy. And what they mean by that is you look at the patient's neck and you see an EJ, like you see it there. So that's really what we're talking about. All right, so let's talk about this. Basically, you're talking about a very large vessel, but the key thing to remember about this whole procedure is that the vessel is under low pressure. In fact, it's under such low pressure that assuming you do an EJ and you disconnect the hub of your needle, you are required to keep it occluded because the pressure could be so low that your atmospheric pressure is actually higher and you could suck air into the line. You're draining straight from the head circulation into the heart. This is one of the last stops on the boat. And therefore, as pressure, starts, ideally 120/80, that kind of a thing, a map of around 100, or 90 or so, it's dropping and dropping and dropping and dropping until it's darn near zero when you reach cardiac circulation. So you've got, your patient's head, nose, chin, neck, and the EJ is running down like so, roughly like that, right? And then you got your heart down here, and when it eventually drains into the right ventricle, you're talking about a pressure of somewhere about 0 to 5 millimeters of mercury. So up here, you're only talking a couple points higher than that. So it could be close to 0. It could be like 2, 2 or 3. It could be higher. I mean, obviously, all of the circulation can be higher in the cases of congestive heart failure or fluid overload or a valve stenosis, that kind of a thing. Anything that will cause higher pressures. But in general, for a normal person, that's where it's at. And this is more being done for your priority 1 patient, your priority 1 victim. We don't just happenstance throw EJs in all over the place. You're not going to certainly do this for a priority 3 or even a low-end priority 2. You're talking about a priority 1 patient. Most of the time we're talking a patient who needs fluid resuscitation, and that's going to cause a big problem for us for this attempt. In no way do I want you to scare you away from it, but the more you know about what's involving with the anatomy and the physiology, the better it's going to make you and increase your chance of success. So the EJ is a huge blood vessel, okay? All the circulation is dropping down into the superior vena cava, and it's a huge vessel, okay? So thinking, talking just like your aorta. I mean, it's not as big as your aorta, but just like your aorta is like a garden hose, this guy is just, a smaller version of the garden hose. So it's big. And you would think that using our normal needles, we should be able to cannulate that thing no problem. So the easiest way to conceptualize this is your big garden hose. Huge vessel inside the body. We're going to use firefighter terms here. This is like your 5-inch supply line. Huge, huge, like the one that the cars get stuck on, or they break out the windows and run it through the car, or the cars that try to get to their house and they can't even get over top of it because it's that big laying across the road. Big supply line. And when you hook that thing up and you completely turn on the valve for your hydrant, usually it comes up to a pretty good level of pressure. If not, it's feeding straight into an engine and it's shooting it down a couple blocks or more to your operational engine, and it's being pressurized, and that bad boy is tight as a drum. You can stand on it and jump on it, and it's not moving. It's not even compressing even a tiny little bit. That's not the EJ, okay? Take the same fire hose. Finish your fire operations. You're disconnecting everything now. What's that hose look like now? It's still flowing water out of it. It's actually still flowing a ton of water. It's flooding the road. But it immediately compresses down. It's under almost zero pressure. Almost zero pressure. So this nice, big, huge, tight as a drum, giant fire hose now looks a little bit more like that. That's your EJ. So it has the ability to carry tons of volume, but it's a big vessel under low pressure. And as the fluid goes out, you're talking almost pancake flat. That creates a problem for us because we're trying to now put a needle with a bevel into it. And that's why when you take this vessel and we introduce a needle, it's really easy to push it right through the other side. Like no problem. Big vessel, you're expecting a big target, boom, you just pop it right through the other side. It's also very superficial. So it's really easy to push it through to the other side. It's completely infiltrate. The other factor is it's so low pressure that it's entirely possible you won't even get a flash on your needle. So now you have no indication that you're in or that you're not in. You might not be all the way into the vessel yet to get a flash. You might have gone all the way through the other side, no flash. You might be 100% in, no flash. Because it takes pressure to run that blood back up the needle and fill that chamber. It's kind of like our pediatric, little hand IV. We're putting in a 24 gauge, no flash. Yeah, the pressure is so low, no flash. Okay, doesn't mean you're not in, just no flash. Okay, so, it's very easy to go through the other side. Okay, so we're going to talk about some techniques that we can do to increase our chance of success, and that's flowing right across the outer aspect of the neck, right across over the sternocleidomastoid. That's the big strap muscle that comes down both sides of your neck that pulls and makes your head be able to go down. You pull one, it makes you turn. Pull the other, makes you turn. Your victim should be in a supine position at this point. Remember, we're talking still a priority 1 patient. Most likely they're massively hypotensive. So that's the other thing is they went from here to massive hypotension to they're super flat. And so, if you were to lay me, you can't see my EJ right now because I'm standing up, but if you were to lay me flat, you'd be able to see my EJ. So that's going to help you right there. So you lay them flat. I'm not necessarily suggesting Trendelenburg. It might be something you might want to consider to help out a tiny little bit. Every little bit can help. But, you're talking, put them in a flat position. So we've got our bevel. Let's talk about our needle choice. My favorite needle is going to be the 16 gauge. I have done EJs with an 18 gauge. The other thing is that when you go in here, it's such a loose vessel. There's so much room for things to move around. And it's such a low pressure vessel that you're used to, even if it's a small scale, even if it's a nice AC right here. My AC pops out pretty good. You probably see that. You can drool over that one if you want. But, you're going to feel a pop you go into that AC. Absolutely, 100%. Put an 18, put a 16, put a 14 gauge. Absolutely, you're going to feel a pop. With the EJ, you tend to not feel the pop. So now we've got a vessel with even a large bore line with no blood return and no pop. That's why we have so many failed attempts at EJs. You got some medics that just swear them off. I've never tried an EJ, I've never gotten a successful one. Just comes down to technique. So they're probably doing 90% of it correct, but that last 10% is what's keeping them from getting to success. I had a mentor teach me, Mr. Dennis Baldwin, amazing guy, my partner when I first hit the streets, and he taught me all of this. And there's nothing in here that I'm going to teach you that he didn't teach me, other than the fact that my personal experience of years have confirmed everything that he taught me was just 100% biblical truth, which amazing guy, amazing medic. Yeah, great guy to be partnered with. I was so thankful and lucky to be partnered with him. So the 16 gauge, the reason why we're not going with an 18 gauge is because it's such a large vessel that you're already not really going to feel a pop. The 16 gauge is actually, interestingly enough, so small that you even feel the pop less. So you're still going to feel a tiny little bit, but I can only appreciate that because I've done so many EJs that I know what I'm feeling. It's not like any other line. Okay? With the 14 gauge, I end up running into that phenomena where the bevel of the needle is so big that I find that I'm keep infiltrating. So for me, the sweet spot is the 16 gauge needle. The 16 gauge needle gives me the most bang for my buck. It's going to be large enough to give me a massive amounts of fluid inflow. It's a large enough bevel that's giving me the most amount of pop that I'm possibly ever going to feel. And it's not so big that I'm always going to just truck drive right through to the other side. So that's this is the best I got. So going with the 16 gauge needle. And I've got my mannequin set up here, but it looks like you guys aren't going to necessarily be able to see it. How can I adjust? It's a little too low. All right, I'm going to pause and reset.